This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
So our final speaker this afternoon is Dr. Simon Rowley. Dr. Rowley is a consultant neonatal paediatrician from Auckland City Hospital. He's an honorary lecturer at the University of Auckland and the chair of the Paediatric Vocational Training Committee. He is a founder member of the Brainwave Trust Aotearoa New Zealand, which promotes education and awareness of the importance of early experience in shaping the developing brain. Dr. Rowley is interested in ethical issues relating to newborns, particularly withholding life-sustaining treatment for infants of borderline viable gestation, palliative care options, and controversies about futile therapies. I'd like to invite Dr. Rowley to offer his intensivist perspective.
I think that's a pretty hard act to follow. And I've been very entertained and enjoyed the parents' perspective. I'd quite like Liz to actually give the same talk for us doctors. The area that we're talking about really is dominated more by opinion than research evidence, and my experience is predominantly in NICU. But whether or not there's a parent who's had a child who has they've had a relationship with for 7 years and loved them and cared for them and enjoyed life with them, and then they face the prospect of losing them, or whether or not they've just had a virtual relationship with the child throughout the pregnancy and then lose them on the first day of life, I think the pain is equally intense and the difficulty with dealing with it is equal. This is just to get people thinking, really. It's sort of a scenario of a 6-year-old, almost certainly severely brain damaged following meningitis, on assisted ventilation, lots of things happening, unlikely to recover, and then only after multiple invasive and painful interventions. So the parents are reluctant to consider withdrawal of, or redirection of care or withdrawal of intensive care, and how should we proceed? The one thing I want to really point out is that for us, these are decisions we make almost day to day when we're working in busy intensive cares. But actually, for the parents, this decision is going to change their life forever. And in neonates particularly, we've got two areas we want to avoid. We want to avoid the death of a child who might have survived without a major disability, and this is the difficulty of predictions and trying to estimate quality of survival. Or we don't want to have the survival of an infant with an overwhelming disability. And we've been, in the past, we've had parents come back to us and said, I really wish you'd not resuscitated my baby. Blah, blah, blah. So this balance of potential benefit over potential harm and distress as a result of treatment is sort of where we're talking. Apologies to Tim, but this is the sort of doctor's sort of rough guide to ethics. We really need to have the concept of beneficence, non-maleficence, respecting patient autonomy and treating patients equally. And I think we're talking here about autonomy versus paternalism, where interests of paternalism include distributive justice and non-maleficence. And we simply can't change every child that's born. But we also don't necessarily have the resources to save every child that's born. And I think often that's the elephant in the room. And because we're not allowed to talk about that with the parents. We're not allowed to say we can't look after your child because we can't afford to. Just before I carry on, I just wanted to talk a little bit about consent in intensive care, because it's sort of interesting. After the Cartwright inquiry into cervical cancer in the 1980s, and then the National Women's Physiotherapy, Chest Physiotherapy inquiry, where some babies who'd had chest physiotherapy ended up with some brain injury thought to be due to the therapy, there'd been no formal consent from the parents to give their babies physiotherapy, and there still isn't in some units. There was a panel set up after that to actually discuss consent in intensive cares in New Zealand, and it involved lay people, parents, including the parents of some children who'd been damaged. It also involved ethicists and lawyers and doctors. And the conclusion was that consent in intensive care is really by the process of information sharing, explaining to the parents what you intend to do and what that entails and why, and then having a discussion about it. And if parents wish to discuss their reservations, then that's when you start to agree or disagree. So blanket consent is not acceptable, and obviously there are certain consents that have to be written. But by and large, we simply don't ask, can we suction your child now? Can we take a blood test now? Can we do this blood gas? We actually sit down with them and say, this is what intensive care is meaning. And often, of course, you have to do that after the event if things have been happening quickly and dramatically. So, advocacy, I think that's the ensuring that your patient has the best deal, is treated equally with fairness, dignity, and ensuring that your rights are preserved. And what about advocating for your child when you know that somebody else is going to miss out on something? Should we consider these equity issues? And we're sort of told, well, actually you've got to be really careful about how you spend the ADHB money. But on the other hand, you're not allowed to talk to anyone about it when it involves their child. And David Isaacs has said it's difficult to argue that it's unethical to advocate for a patient to receive a disproportionate amount of the pie when the pie has no fixed size, because we don't know what the size of the pie is. So that's another dilemma I think we have. So what about paternalism? This is the intentional overriding of the parent's wishes by the physician in the interests of avoiding unnecessary harm, and that's often where we're left thinking, well, should we do this? Seen by some as the opposite of autonomy. When you survey parents, they indicate most favour shared decision-making rather than autonomy, be offered choices and ask their opinions. But actually, about 40 to 50% prefer to leave the final decisions with the physician. And a lot of people have said, well, we should have benevolent paternalism, which is where you try and second-guess the parent's wishes and then put it into the words so that you're seen to be making the decision that you've decided that they would like. And that's hugely inaccurate, and studies have shown that to be very inaccurate. This was a paper looking at open-ended discussions, the role of palliative paternalism in difficult medical decisions. And this paper actually made the points that what's been happening is that these days there's a trend amongst physicians to avoid difficult medical decisions by hiding behind the fact that the patient should have autonomy or the parent should have the autonomy. And they, in this paper, argue that paternalism still has quite an important role in decision-making. So where patient preference dictates care, then that's not really what they think is in the best interests medically. Paternalism is a little bit like, you could say, well, we simply don't intend to offer further intensive care. And then you could put it in somewhere else, you know, in another frame if you wanted to. But would you like us to continue offering intensive care for your child? Or we're not sure whether that's the right thing, you decide. And we had a situation a few years ago where vitamin K for infants after birth was regarded as, there was a paper published that suggested it might actually cause childhood leukemia and cancer. And subsequently this paper, which got a lot of press, led to all the midwives working around the place either not giving the parents, the babies, the option, the vitamin K, just avoiding it, or advising against it. And the paper was actually flawed. There was a lot of informational bias, and eventually people decided that actually giving babies vitamin K didn't cause cancer, but it still was evident that giving vitamin K stops about one baby in 500 of getting a serious bleeding disorder. What we saw in the delivery suites was midwives saying to the parents, look, I don't know about vitamin K, here's the paper, you read it and you can decide. And I think that's pretty tough. So what about quality of life? So that's where I think paternalism is confusing. So if we want to make difficult decisions, what are our principles going to be? Well, I think you're really out on a limb if you make a decision about not treating a child and you're not in agreement with your colleagues. So we need to be aware that we're keeping up with what everybody else is doing, and we're in the process of having that discussion with neonatal units around the country about whether we resuscitate 23-weekers or not. And it would be nice if we were able to keep up with what intensive care units around the world and neonates are doing. So you need collegial support. I think you need to be within the law, and what you need to do needs to be defensible. You need to have parental agreement, and that's what we're talking about here. Would you like me to repeat it? So, I think just while we're on, while we're on the law, it's been shown that when people ask parents, when parents ask or people ask lawyers for their decisions about things, if they ask before the event, okay, this child looks like he's got a hopeless situation, we'd like to discontinue treatment, intensive care treatment, the lawyers will always say, no, don't do that, we'll go for life. But if you do that, and then ask them, so you ask them after the event, was it okay to discontinue intensive care on this child because the outlook was hopeless? Then the lawyers say, yes, that was okay. So it's a little bit like, you know, do you ask permission or do you just ask for reassurance once you've done it? So you need to do what's within the law. You need to have parental agreement. And I think we use ethical committees sometimes, not that often, but we have certainly used it in a number of cases, and it's been very helpful when we've been at an impasse with parents. So in medical decision making, I think it's really hard when you've got young families who don't have a lot of life experience and don't have any intensive care experience, and Liz illustrated this beautifully, to try and work out whether they really understand the decisions that we are making with them. There's lots and lots of papers that show that our views in the medical and nursing profession are quite elitist. So we think that actually anybody who's even mildly disabled shouldn't really be alive. I think when you look at neonatal surviving kids that are in their 20s and early 30s now, they all say the disabled survivors rate their quality of life equally to the non-disabled survivors. I think we need to acknowledge that no one individual is ever the same, and that's that the probability of that is that we can make statistics for anybody and say, well, you've got a 50% chance of survival, you've got a 90% chance. If you survive, you've got a 95% chance of being normal. But actually, for the individual with life and death, it's either 0 or 100%. You're either dead or you're not. And if you're either alive and normal or alive and seriously brain damaged in some situations. So I think we just need to be aware that that for each individual case, we often have to sit down and discuss that on its own. So this was another paper in 2008. Makes the sort of point that the utility of a particular outcome may be altered by the frame of reference of the decision maker, i.e. how you frame the situation will determine how the patient or the parent receives that information. And they've done a really interesting study where they actually gave a whole lot of neonatologists a scenario, and they said, well, you've got a 23-weeker, he's got a 75% chance of survival. And then they framed it again and said he's only got a 25% chance of, he's got a 25% chance of mortality. And then they looked at the quality of survival and gave the same sort of figures. And depending on whether you framed it sort of as survival or mortality, there was a huge difference in how these people answered the questions. And that's just people who should know better So I think we have to have enormous power when we're framing things to parents and saying, well, we think things are hopeless. We can actually sometimes use our silver tongues to get the effect that we want, and that can be a worry. So what do we try and do in our NICU? And I think this is not a bad... I found this transparency model actually in a nursing journal a number of years ago. But what they suggested is you think out loud your decisions, so that if you have a baby who you're starting off a journey with, or a child in intensive care, you're starting off trying to work with them, that every single point along the line that you have to make an important decision, you discuss it in detail with the parents, in language they can understand, so that you're keeping them informed every step of the way. So for a newborn, it might be a preterm baby. The time they get their necrotising enterocolitis, you've sort of discussed it with them and said, well, this is what's happening, the feeding's not going well, and we'll have to rest the bowel, and the bowel might have to be cut out if it's all damaged. And then you get to that point, and you may or may not have to do that, and then you move on, and then the baby has a brain hemorrhage, and you say, well, if it's a bad hemorrhage, it might mean some serious things for this baby. And as you go through each point of the way, they're with you all the way along, so that when you finally get to the point where, wow, not only has he had a brain hemorrhage, he's had necrotising enterocolitis, but he's actually now got pneumothoraces, and we know that he's on 100% oxygen, and they're often the people that can say, do you think it's worth going on, doctor? I know it's tough for us to say that, but I think sometimes they do feel like they have some involvement and some power if you're actually discussing it with them all the way through that time. So for me, my personal dilemmas, well, I think I have to ask that question about being silver-tongued. Is it okay to be persuasive and convince the parents that my way is the best? Is there a difference between withdrawal of intensive care and then giving a lethal injection? Because in both cases, the child is going to die. How honest should I be in discussing resource issues? We simply don't have enough to be able to say, we can do everything for your child. So, I think we need to be gentle but firm, be directive, and be humane. We need to be transparent in our communication, because whenever these situations arise where parents want unreasonable treatment, I think it's the root of the problem is that we haven't communicated well with them. We need to be inclusive in our discussions with the parents, but also to ask them to involve their family and their church or whoever if they feel they would like to. I think we should be compassionate and acknowledge with the parents that we're sad about what's happening too. We need to know our details. We need to have our facts absolutely straight if we're going to have these sorts of discussions, because we as clear as we can be, we have to be able to frame this. But in the end, I think we should be prepared to say, no, we don't offer this. I'm not going to offer this care for your child, and because I think it's the right thing to do and it would be wrong to do otherwise. And I'm the doctor. So, trust me.